my colleagues, my friends, and my juniors also. And of course, a very, very warm welcome to Dr. Arup Kumar, who has accepted our invitation to speak on progesterone and placenta accreta. I welcome you, sir, personally on behalf of AOG's family. I welcome all my chairpersons and my secretary, of course, Dr. Poonam, who is the backbone of this year's AOGS, and Dr. Arup Kumar Majhi. He is from Calcutta presently. He is Professor Obs and Gynae in Shanti Niketan Medical College, Birbhum, West Bengal, and formerly he was the HOD and of Obs and Gynae in R.G. Kar Medical College, Kolkata. I extend a very warm welcome to you, sir, once again.
First, my great thanks to all of you, the members of Agra Obstetrics and Gynecology, for inviting me in so prestigious evening gathering in the Agra, the historical place in the world history. And Agra is actually not the first time. I have come here several times, the AICOG and also a SAFOC conference here, and attended many academic program. But this time actually I am very, very proud to be invited by the Agra Obstetrics and Gynecology Society. So, Madam Dr. Sushma and all of you, my great congratulations for inviting me. And all of you know the progesterone in prevention of preterm birth. There are some recommendations here, and preterm birth is actually one of the most burning problem in obstetrics, with the other problem, the second topics also. And there is very little to do about when a woman goes into preterm labor, established preterm labor, nothing to do other than the care of the NICU and the management of the neonate. But recently and for few decades, and there are some intervention to prevent the preterm labor, medication, and third is the actually to know the risk factors, modify risk factors, and to modify them. This is the basic three things of the management of the prevention of the preterm birth. And so today discussion about the preterm birth with the progesterone will be limited to the preterm birth, what is the present scenario, and second is the how to screen. If you want to prevent anything, I will have to screen. So for all people we cannot do, and it is not justifiable also. And next is the evidence-based management and the recommendation. That is I will highlight, because you know there are so many recommendations from worldwide, but ACOG, NICE guideline, and SOGC, these three guidelines are almost tell the same thing about the management of the preterm labor regarding the use of the progesterone. That is the natural progesterone, and ACOG to some extent the 17-hydroxyprogesterone, and they are now withdrawing that drug. Any synthetic drug will be withdrawn within few years, you will see. And progesterone and synthetic progesterone role in the preterm birth. Controversies and consensus on different formulation. There are so many formulations, and natural progesterone, oral synthetic 0/7x of gestation. This is the preterm labor definition, standard definition, ACOG 2021. And preterm birth, in spite of several strategies to taken, ranges 35% of all days among newborns aged less than 28 days. And not only the death, but also the morbidity of the preterm birth. All of you know, there may be very preterm, there may be early preterm, there may be late preterm. The baby suffer from different disabilities. That has to a strong economic burden to that country. Now, reasons of preterm birth, suppose severe preeclampsia and severe diabetes medically indicated by maternal and fetal distresses like that. We'll have to deliver. So these are the three groups, the causes of the preterm birth. Now, tocolysis for delaying delivery in patient experiencing spontaneous preterm labor has been largely unsuccessful. When it is established, more than 4 centimeter is very unsuccessful by giving there is only the short-term effect of the efficacy of the tocolytic drug, not the long-term effect. And attention has focused on preventive strategies. The most important is the identification of the risk factors and their prevention. So what are the risk factors of the preterm birth? I am not going into the detail in this evening about that. There are so many you will get in the books. Previous history of the preterm birth, that is the most important. If any woman has the previous history of the preterm birth, there is 1.5 to 2-fold increased risk of the subsequent preterm birth. So that is one candidate we will have to prevent by any intervention. And social factor, that is the low socioeconomic structure, anemia, and work hard, there may be chance of preterm birth. Uterine factor, all of you know, the over distension of the uterus, the multiple pregnancy, polyhydramnios, congenital anomaly of the uterus, submucous fibroid cause the preterm birth. Cervical factor is the one of the important factor, and that we can do. Short cervix is called, well, it is the less than the 2.5 centimeter of the length of the cervix, and this is all guideline says that should be done. Something done mostly by the circlage operation. And cervical congestion of loop surgical excision, transposition and D&C are the important risk factors from the preterm birth. And other obstetric diseases like the preeclampsia, antepartum hemorrhage, other diseases, hypertension, diabetes, thyroid disease, renal disease, etc. And recently it has been found the periodontal disease. When a woman comes in the antenatal period with dental gum infection, you must have to treat. And it has been seen there is a strong correlation between the periodontal disease and the preterm birth. And premature rupture of membranes, genetic factors, and idiopathic, in all spite of searching for all the diseases, the idiopathic is the 30 to 50%. And most important is what are the modifiable risk factors and diseases. Lifestyle management, the smoking and drugs, cessation, correction of the weight, avoidance of the strenuous work, correction of the anemia, treatment of the diabetes, hypertension, preeclampsia, antepartum hemorrhage, treatment of infections, lower genital tract infection, bacterial vaginosis, UTI, and treatment of the gingivitis. So these are the modifiable risk factors. What are the strong predictors of the preterm birth? That is very important. Because the prediction you will have to do which woman will go into preterm birth, labor. History of preterm birth is the most important, I have already said. Length of the cell, already said. And presence of the fetal fibronectin, no effect by the progesterone or by the circlage. No effect. No treatment is not known. But the above, first two, there is some preventive strategy. Prevention, to prevent the preterm labor, so we will have to screen the mother. Screening of the high-risk groups and management accordingly and intervention. That is our principle. How will you do the screening from the history, who are the high-risk women, clinical examination, digital cervical, PV examination with the digital, whether this is short cervix, then you go for the ultrasound, speculum examination for presence of the leaking and infection. If the woman complains of the white discharge or excessive discharge, we will have to see whether this is the PROM or not. And sonography, that is the cervical length measurement. And screening by ultrasound cervical length, there is some guideline by the ACOG. Like the placenta accreta spectrum, we will have to screen from the early and during anomaly scan. And you will have to do particularly for the high-risk women, the screening by the ultrasonography, particularly the length of the cervix. The single-tone pregnancy, no prior preterm birth at time of the anomaly scan. So, anomaly scan routinely we should see what is the length of the cervix. And in fact, this has been the standard protocol in the every obstetric setup to measure the length of the cervical cervix. And single-told pregnancy, the prior spontaneous preterm birth, serial TBS from the 16 weeks and repeated until 14 7 weeks. And multiple gestation, at that pessary use some group of people. And most important is the regular antenatal care and detection of the high-risk groups and management of the modifiable factors. And aspirin, calcium for prevention of the PIH. We know the prediction of the and prevention of the PIH regarding in the only answer for the prevention of the PIH is the aspirin, if there is the suspected growth, and also the calcium. In calcium, it also prevents the hypertension, preeclampsia. In other country, they do not use the calcium routinely, but in India, women are basically the calcium deficient country. That is why iron and calcium given routinely in India. And also the Indian NHM has also guided Government of India guideline. The both should be given and calcium should be routinely given. If you go in the NICE guideline, it is not routinely given. And smoking cessation is the important. Now, rationally for the progesterone supplementation, what is the rationale? There are so many detailing, but I am not going into that. The endogenous progesterone contributes to the pregnancy maintenance in several ways. It is well-known and well-known fact. And therefore, exogenous progesterone likely to enhance this action. Actually the progesterone action by reducing the calcium flux and also inhibiting the inflammation that may cause preterm large. Basic action of the progesterone, the exogenous progesterone. Preterm birth prophylaxis. Now regarding the prophylaxis with progesterone has been studied since 1960s, even before with many reports showing a benefit. It is well recognized that progesterone therapy is an important intervention in prevention of preterm labor in susceptible group. It has been established and FDA from 1960 onward, they are using the injectable 17-hydroxyprogesterone caprate. They are using. And role of progesterone in preterm labor, progesterone crucial for maintaining uterine quiescence in the latter weeks of pregnancy. Functional withdrawal of the progesterone activity at the uterine level and sit in the early onset of labor, both at term and preterm. The observation is the basis of progesterone supplementation in prevention of preterm labor. Now recommendation, you just see the recommendation. Almost 3 recommendations are almost same. There are some variation. I will show the what ACOG recommends, and then what is the some variation with the SOGC and the NICE guideline I am showing you, nothing more. If you see single tone pregnancy, no prior preterm birth, short cervix, progesterone supplementation indicated or not? Yes, progesterone supplementation indicated. Single tone pregnancy, prior spontaneous birth, normal cervical length. Prior spontaneous birth, you give the progesterone. Then serial every 1 to 4 weeks endovaginal ultrasound measurement of the cervical length beginning from the 16 weeks of pregnancy, repeated 24 weeks of gestation. You also give, yes, if you see there is the cervical length is small. Single tone gestation, prior preterm spontaneous preterm and a short second trimester cervix, both are present. What will you do? There is some difference of the opinion. ACOG says use circlage addition with the progesterone, additionally circlage. But SOGC, the Canadian organization, said circlage is not needed. And even only the progesterone may be superior, not just language is there, superior alternative therapy with the, when there is also short cervix. That is one difference from the SOGC. But NICE guideline, same. And the single tone pregnancy, prior spontaneous preterm birth, normal cervical length, short cervix, consider performing circlage. Maybe, this is not strict guideline. Multiple pregnancy without prior preterm birth, normal cervical length, no progesterone no, but that is the present pregnancy. Only routinely whether, and sometimes with multiple pregnancy, we know there is a chance of the preterm birth, whether give the progesterone routinely. Some groups also give. Some groups, in some cases, the progesterone is, as there is no natural progesterone, they prescribe. But it is not recommended. Twins prior to preterm birth, maybe. And PPROM, there is no effect, though there is no effect of the progesterone. Positive fetal fibronectin test, no progesterone. Undelivered after an episode of the preterm delivered, no use of progesterone, not recommended. And NICE guideline has additionally added something what the SEOG. Cervical length of 25 millimeter or less, that is one indication of the progesterone and also the circles. PPROM in a previous pregnancy, that is the addition of the NICE guideline. And also the history of the cervical trauma, like conization, like that. This is the, you will see the NICE guideline, they have added, this is the only addition. Baki, all other things are the, like the SEOG. Now, come to when to start and duration. Previous spontaneous single tone pregnancy, preterm birth, and beginning in the second trimester, where there is a history. Second trimester, you use from 16 to 20 weeks onwards and continue through 36 plus 6 weeks of gestation. And mid-trimester cervical shortening, if you could diagnose, to start from diagnosis of the short surface until 36 plus 6 weeks of gestation. If you see the cervical shortening at the anomaly scan, otherwise normal pregnancy, normal history, you start at that moment. Pregnancy is high risk for preterm birth, where the benefit of the progesterone is supported by many studies, strong evidence yet to come. That is, I was telling all of you, that is thing. Sometimes you can use the progesterone. Maintenance therapy after threatened preterm labor. Threatened preterm labor is actually the vague term. Threatened preterm labor, sometimes the uterine contraction, no dilatation of the cervix, no progressive dilatation of the cervix, and gradually ceases the contraction. Uterine anomaly or assisted reproductive technology. Now the assisted reproductive technology is the high risk pregnancy, so it can be given. And uterine anomaly, there is a chance of the preterm labor. There is no such recommendation, but many groups give. Patients with obesity, this can be given. Now come to the, what are the types of the progesterone and what are the dosage used. One is the oral micronized progesterone sustained release, 300 milligram, 200, 400 also available. 300 milligram is the standard dose, 300 milligram. Vaginal micronized progesterone capsule, 100 to 100 milligram twice or thrice daily. Vaginal progesterone gel, 8%, 90 milligram every night, gel. And intramuscular progesterone, that is the natural progesterone, not the synthetic, 100 to 200 milligram at alternate day. And 17-hydroxyprogesterone, this is the synthetic intramuscular, 250 milligram per week. Only the SEOG recommends, no other society recommends the 17-hydroxyprogesterone. I am claiming why the other groups do not use. Now, controversies and consensus. When you will use, which type of progesterone you use? Synthetic or natural? Which route? Injectable, oral or vaginal? If oral, synthetic or natural? We are confused, many obstetricians and consul. So we will have to determine in our country of India, by here, and also the availability of the drugs, and also how the compliance of the drug. That we will have to think all the thing. I am coming on that. And also the efficacy and safety of the drugs. Recommendation of the types of progesterone for preterm of labor. Now, if you go to the recommendation, all groups recommend natural progesterone are universally recommended, not the synthetic progesterone. And even not the dydrogesterone is not actually the natural progesterone, though many people demand dydrogesterone, that is the stereoisomer of the natural progesterone. And stereoisomer, you know, many of the stereoisomers have the different effects. And it is the natural progesterone recommended. And dydrogesterone is not recommended by any society for routine preterm labor, prevention of the preterm labor. Among the synthetic progesterone, only 17 alpha hydroxy progesterone caprate injection is recommended by ACOG, but ACOG does not use it in case of short cervix. Short cervix, they do not recommend. The 70 is not recommended in all cases, that is not in the short cervix. So, for choosing a progesterone, we will have to consider now the acceptability, that woman will accept or not, the compliance, whether she will use or not, and the efficacy of the drug, and the safety and adverse effect of the drug, and cost and the affordability. These are all things. To remember it, that progesterone, it is not a magic. Not the magic like the Maxalp, it will prevent the eclampsia, and not the magic. Still, the progesterone is not a panacea. Spontaneous preterm birth would be reduced by no more than 20%, and whatever progesterone you use, an absolute preterm birth rate would be reduced by no more than 0.01%. And so efficacy, if you see, in vitro and animal research suggests that there are several studies. The progesterone, type of progesterone, formulation, dose, route of administration, and plasma concentration, which varies among patients receiving progesterone, also impact the efficacy. And progestogens used clinically are basically two groups. Actually, the progesterone, progesterone is a first discovered in 1941 by the Russell. All of you know 1941 progesterone, natural progesterone was discovered, and the synthetic progesterone was discovered in the 1951, and at the same time progesterone was proved as the only, that is the contraceptive agent, and Pincus and Rock, and they have a study in 1953 published a paper for the contraceptive agent. And USA, from the USA, the oral progesterone and estrogen combination was approved in 1959. So if there is some postgraduate, this is a very common question: who discovered the progesterone when, who discovered the synthetic progesterone when, who discovered the oral, combined estrogen progesterone and trial, and then when first available of the drug. In fact, for the postgraduates I am saying, actually the progesterone is the contraceptive drug, not the estrogen. The why estrogen is giving, it is added, originally the menstrual is added, now ethylene estradiol is added, original tablet, that is the menstrual. Why it was given? It is given to prevent the breakthrough and to some extent to increase the efficacy. So the end of the 50, there are 59 for oral progesterones, when the oral contraceptives was available at that time. And progesterone, if you classify the progesterone, you see the simple classification. Postgraduates, you see the progesterone is derivative. Progesterones are called, these are called progesterone, progestogen, gestagen. These are the different names of the progesterone. Same, any compound which has the progesterone activity, that is called. And progesterone and its derivatives, and another is the testosterone or 9-testosterone derivative. Regarding the progesterone and its derivative, the natural progesterone is the 21 carbon atoms that is available in the oral, vaginal, rectal, and injectable. And stereoisomer is the 21 dihydrogesterone. This is not natural progesterone, only orally available. And esters of the sulfur 17 alpha hydroxy progesterone, this is the progesterone derivative. And the medroxyprogesterone commonly used. But these majority of the drugs are used only for the gynecological purposes. And testosterone or 19 testosterone derivatives, actually, that include like the first generation, second generation, third generation, and fourth generation. Linosterol, levonorgestrel, norgestrel, and lateral desogestrel, and desogestimate. These are the, not gestimate, these are the different drugs, but mostly common either in the oral contraceptives or gynecological condition. But obstetrical conditions, as I can remember, I am the student of the Professor B.N. Chakraborty, And he used, I have seen my when house surgeon, there was the synthetic, the progesterone derivative synthetic progesterone used in the early pregnancy. But it has been proved that don't use some random on in case of early pregnancy progesterone. The natural pregnancy progesterone is the safe. So that has been gradually withdrawn. You don't just in many drugs you will see the senior people use that drugs are gradually withdrawn from the use in the pregnancy. And so this is the very important for the postgraduate. And if you see the serum progesterone level with various progesterone formulation, you will see the oral sustained release tablet, and it has the highest of the mean serum concentration. And this is the Indian study also. This also says the Indian study. Progesterone SR population attains more than 14 nanogram plus serum progesterone level. And data on the synthetic progesterone and progesterone, that is very important. You see, the 70 hydroxyprogesterone acetate. The preterm birth prophylaxis of the progesterone has been studied since the 1960s, even before. All of you can remember a very senior person who are the progesterone, the progesterone 17 hydroxyprogesterone caprate was frequently used in the threatened abortion in our early days. But it is not so much used and recommended for routine use in case of, because these had some teratogenic effect. Now, only FDA has now approved for the preterm labor, but gradually they are also withdrawing. And in 2003, administration of the 17 hydroxyprogesterone was broadly recommended for all patients with preterm birth by ACOG and Society for Maternal Fetal Medicine. 17 alpha progesterone remains the first and only drug approved by the FDA for the prevention of recurrent preterm birth. Currently, the views are changed, and 70 hydroxyprogesterone is now the focus of the controversy. Particularly, there are so many landmark papers in last 2 years. You will see. Overall efficacy has been questioned, that is the prolonged trial that has been published very recently, and it is inferior to the natural progesterone. That is, we are talking about the injectable synthetic progesterone. And there is increased risk of the hypospadias in male offspring if used before 11 weeks. In our younger days, we have used so much. I do not know actually, but the study has said. And a 60 years follow-up study, 23 cancer had been diagnosed 70 hydroxyprogesterone exposed offspring. If you see, it is used from the 1960s. The 40 years and now is the more than 20 years. 60 years, that off-skin woman has been studied, and who have not 17 hydroxyprogesterone and who have taken 70 hydroxyprogesterone, the increased risk of progesterone, that off-skin. That is it has been studied from the 60 years. That is very, very recent study. The one is the landmark study by the Murphy et al. Study is published in the 2022. Injectable route IMSC subcutaneous to continue for surge prolonged tubal is not universally acceptable. And it is an inconvenient, the injectable progesterone using. So 70 hydroxyprogesterone may be withdrawn with no more than giving a permission of off-label use. If you go through the recent Williams 2020, not going to the other literature, they have quoted all the things. The FDA concluded that the prolonged trial did not demonstrate a treatment benefit of the 17 hydroxyprogesterone. The committee recommended to withdraw approval. And in November 2020, the Center for Drug Evaluation and Research proposed that the Macanal, that is 70 hydroxyprogesterone caprate, be withdrawn from the market. And FDA 2020. At this time, the FDA has not withdrawn the accelerated approval, but gradually they are withdrawing. And it is the off-label use. The problem of the off-label use of the other country will not get the insurance benefit. Now it is the transitional phase. Now coming to the oral synthetic progesterone. I have highlighted there. Oral synthetic progesterone, dydrogesterone, it is the stereoisomer. 2 hydrogen atom less. Dydrogesterone is a stereoisomer, and it is synthetic progesterone, not natural as usually we demand. This is the natural progesterone, the dydrogesterone. And even it is not recommended so much. And sorry. Dydrogesterone is not an effective progesterone in preterm labor. Preterm labor, it is not effective and not at all recommended. Mostly used in the luteal phase support. Many of us use in early pregnancy, especially in infertility and ART, due to luteal phase insufficiency. Common adverse effects such as the headache, dizziness, abdominal pain, flatulence and nausea occur more frequently with dydrogesterone. However, its safety for the offspring is not out of question. There are so many, I have only one paper I am just presenting one paper. The conclusion is that so many papers on that we identified a positive association between dydrogesterone usage during early pregnancy and congenital heart disease in the offspring. Nevertheless, further studies are needed to confirm this result. If you see the summary between the natural micronized progesterone difference with the dydrogesterone, the identical structure, but dydrogesterone is the natural progesterone is the identical progesterone, and USA FDA approval. Natural progesterone is approved, but dydrogesterone is not, it has been withdrawn. And European Medical Association approval, natural microprogesterone is approved, but dydrogesterone is withdrawn. Conclusion of the Cochrane's review 2021 on safety, you say, the moderate and low certainty evidence suggests that there is probability no difference in the congenital abnormality or using of the natural progesterone. But regarding dydrogesterone, uncertainty over the safety. So pregnancy category TGA Australia is A, but dydrogesterone is stand-alone drug not available in there. So what will you use, synthetic or natural? If safe natural preparation is available with equal efficacy, so what should we use? Is synthetic molecule safe for the mother as well as the offspring? All the studies showed that the synthetic, there is a great question mark. It is really safe for the mother and the offspring. So choice, if you think the choice is the natural progesterone. Now, which route you will use? Vaginal or oral? Vaginal or oral? The problems of the vaginal progesterone is that combustion, inconvenient, vaginal irritation or discharge all led to non-compliance. If you choose the non-Indian, the guidelines say used the vaginal progesterone. But how many Indian women, particularly women, they are accustomed with the vaginal progesterone? If it is, so doctor, if it is available in the oral, so please you give the oral tablet. So all Indian women are not motivated. Limited number of motivated group like women receiving ART are motivated, but not the general population. You can motivate ART patient. They will motivate whatever you will give. I have seen the gestone injection day after day, so painful injection, gestone one type I have seen, but they are motivated to get only for a baby. Only they are motivated, whatever you see. If you say the 0.001% efficacy more, she will say that they give you. So need of a safe, efficacious, ideal oral progesterone. Now come to the oral natural micronized progesterone. There are so many stories real the natural micronized progesterone. If you see the history, the natural progesterone was not used when the Russell discovered it, could not be used because it was not absorbed at all. And if it is absorbed, it is a quick bypass effect. So efficacy is less. But after that, and I have gone through all the pharmacology actually regarding progesterone. I have a good article on that progesterone. After that, what has been done? That has been micronized, and there is a lipid coated. Micronized for the more absorption, and lipid coated to the limit the first bypass. That is used. That is the original natural progesterone. But till the vaginal progesterone is used, that is for the local effect. And vaginal progesterone acts directly on the uterus, bypassing the systemic route. The efficacy of the oral progesterone may be questioned because of a significant first pass effect from hepatic metabolism. Although studies outside of pregnancy have shown similar viability as vaginal administration. Absorption, viability, and first pass effect from hepatic metabolism are overcome by the vaginal route. That is the basic of the using of the vaginal progesterone. These problems are with the conventional natural progesterone formation. But when the sustained release progesterone has come into the picture has been changed. Oral natural micronized progesterone sustained release has overcome the previous problem of the conventional natural progesterone. Oral SR formulation has equal advantages of the vaginal route so far efficacy and safety is concerned. Benefits of the oral natural sustained release micronized progesterone over the conventional oral progesterone. Reducing the particle size less than 10 micromillimeter, increase the available surface and improve the dissolution rate and intestinal absorption. And sustained release formulation utilizes a hydrophilic matrix polymer that releases micron-sized particles of progesterone in a controlled manner over 16 to 24 hours. This gradual release maintains the serum progesterone and that can be done with once daily dosing. Two recent landmark meta-analysis on use of the oral progesterone. If you go to the up-to-date is the most, if you go through that, the two recent, you will see the American Journal of Obstetrical Gynecology 2009, the oral progesterone for the prevention of the recurrent preterm birth, systemic review and meta-analysis. And another is the evaluating progesterone EPPPIC study meta-analysis. This is the landmark study recently, both are very recently, and one is the 2019 meta-analysis and 2021. Comment of the AGOG study, that is, what is that? Oral progesterone appears to be effective for prevention of the recurrent preterm birth, a reduction in perinatal morbidity and mortality rate. Although oral progesterone does undergo an hepatic FAST, but effect, based on this review that does not preclude its efficacy, there is increase in serum progesterone, a reduction in the preterm birth. Further randomized study or oral progesterone compared with other established therapy for the prevention of the recurrent preterm birth are warranted. In fact, what has happened, I have seen the literature, on searching the literature, the work on the oral progesterone, oral sustained release progesterone is less in comparison to the vaginal progesterone. And it has been documented in repeated. There are so many studies of the oral progesterone. Recommendation of the oral natural micronized progesterone according to other studies also. Oral and vaginal routes are equally efficacious. Oral natural micronized progesterone sustains over a better compliance and convenience to the vaginal capsules. Some studies conclude that a significant beneficial role in LPD, LPS and ART and bad obstetrician for preterm labor. So there are so many studies actually, oral progesterone. So here this evening I cannot make you bored. That is some slides are deleted. So there are so many work on the study on the oral progesterone. Preterm birth has multifaceted etiology and is a huge financial burden comprising of 11% of the all birth. Recent reports suggest that prevention in a selected population may be achievable. Using progesterone to prevent preterm labor, especially in women with a definite history of the spontaneous preterm birth in past and those with the accidental short cervical length on routine skin. That is, the routine skin is necessary at the time of the anomaly scan. Anomaly scan, one that is should be the routine, one is the length of the cervix and another is the position of the placenta. The routine scan, particularly if the previous history of cesarean section, whether the placenta accreta spectrum or not. At the time of anomaly scan, please ask for cervical length. In your obstetric practice, I will request all of you who ask the cervical length. There are many sonologists, those obstetricians and sonologists, they do that thing. But the other sonologists do not do. In short cervix, cartilage is option, and progesterone is equally effective and even superior to the cartilage as SOGC canadial guidelines says. When tocolysis is achieved in preterm labor, consider using progesterone for maintenance. All ART pregnancies carry the risk of the preterm labor. This is not recommended, but this is the high risk pregnancies. Risk of preterm labor. Advise progesterone for the prevention of preterm labor. Of the synthetic, natural, oral, vaginal injective preparation, naturalized micropolarized progesterone sustained release is a very, very good option in reduction risk of preterm birth so far as efficacy compliance and safety are concerned. Thank you all. Thank you for your presence here.
Thank you, sir, for such a comprehensive and enlightening presentation.
That how in-depth knowledge you have. One thing I am a little worried that because those cases which have history indicated preterm labor, intramuscular progesterone was the thing which was being used for years together, and now it is being withdrawn. That is something which seems to be a little...
History of preterm labor, what is the question?
With those cases who had history of preterm labor, for them, for prevention of preterm labor, it was the intramuscular progesterone which was being used, 17-alpha hydroxy, which was being used for years.
No.
But now, as you say, that reports are coming that it is being withdrawn. The FDA approval is also being withdrawn. It's...
regarding the 17-hydroxy progesterone.
Yes.
But Madam, I am requesting you to just go through the recent Williams UC, the last edition. Okay. It has been 22 early.
Okay.
Williams UC, details has been, and from there so many references you have seen. The two important studies actually, the 17-hydroxy progesterone about 60 years back, 60 years study they have seen. There is increase the cancer risk. Not only the offspring, the congenital anomaly, hypospadias and like that. That is from the early months you should not. But 17-hydroxy progesterone will be, they are the only FDA approved as given only for the off-label use.
Because otherwise, routinely, natural for them, the routine checkup is not possible. Usually, that was the thing which was being routinely used. That's why I was really interested.
Injectable is the once weekly. Actually,
so as you said that
I have actually here today, I have given you all the facts and what is the present scenario of the use of the progesterone of the preterm birth. I have a good article on the progesterone. In it, I have written in 2009 or 10 article. I have seen that just going through the that was at that time was not so was the preterm birth.
That's
and nice. Actually last 2 to 3 years there has been tremendous change of the opinion, and you will see the coming 5 years the natural progesterone micronized will come in the way. You will see.
Otherwise, it is on the way. But those who are not able to come routinely, for them it was being used. That's why I asked.
Okay. Our teacher says you do the treatment, but you do treatment in such a way that is not harmful.
Yes.
That is not harmful.
So
cannot good for the patient, but you don't do harm any. That is very the lesson of our teachers.
Really, a good message has to be.
New chapter ISOPARB, and Dr. Arup Kumar Majhi is the national president for that. So let's give a very big round of applause. And the first meeting would be held in April in Meerut. So everybody can block your dates. And I think we can, so a big congratulations to you, sir.
Thank you all. I think it is very fortunate. The Bharti Madam, I asking for talking with the Bharti Madam, she has taken the merit to a very near place, and I think all of you go handover ceremony. I will take the charge from the Dr. Gangadhar Sahu officially from there actually.
So nice. And in
future will come and many program. Particularly, basically, I am a teacher. I have 30 years of experience. I have written the book. Actually, the 3 books I have written from my experience. You will see it is for the very places, other states places I have gone for teaching program. Like Delhi, I go frequently, Chennai, I go, there's a teaching program. The cases, they keep the cases, long cases over in the different cases. What could be the question, or also the virtual through COVID. So you can arrange for the postgraduate. That will be very, very
We
good.
all are going to benefit from your knowledge, and for that reason, I would say, can we go on forward with the next talk?
Definitely.
And we can share our clinical experiences after this.
That is also very important topic. Very important topic. The patient come with the patient morbid addiction, and we used to manage. It was a nightmare. And sometimes, what will you do tomorrow? I will do cesarean section. What will the patient? Or will they build it? Even I show you one picture in 2014. After the cesarean section, the baby was removed and tried the placenta for removal, and the patient was cardiac arrest there, And many patients die actually, died. I have seen, because I, actually state government, many cases I have deal also. I have seen the Placenta Accreta Spectrum. And that patient actually 12 units of blood products given, ultimately revived at 33 weeks. I will show the picture. But recently, only after the guideline, it the, all of you know, the ACOG and the RCOG guideline, and later on the FIGO, what has been written in the FIGO guideline in 2018 onward. They have streamlined the management of the Placenta Accreta Spectrum. If you now ask what is the streamline, I want or so. If there is a strong invasion of the placenta in the scar, usually it occurs in the scar, and there is a patient is not so eager for the baby, and she has another baby. So you do the cesarean obstetric hysterectomy. This is the guideline present. And if you think clinically or ultrasound baby, there may be invasion, or probably there is not invasion, only the placenta 1, 2 like that, not so invasion, you can remove the placenta. So this is the take-home message. And there are so many management, there are so many surgery has been done, attempted from worldwide. What FIGO has been there, I just summarize. It is not possible for half an hour lecture. FIGO, the different operations. But I will show what I do in my cases. I have 25 PGs every year when I retired. Now in the New York Medical College, and 75 PG I had to deal when I retired at that. And they were very expert. If there is any Arjikor people in Agra or Aligarh, you will ask them how they have learned the surgery of the obstetric cases. So Placenta Accreta term, it is not a new. It was first described by the obstetrician Irving and pathologist Hartig, Boston in 1937. And PAS disorder first defined by Luke et al. PAS disorder, 1966. Various nomenclature, Placenta Accreta Spectrum, morbidly adherent placenta, and Placenta Accreta syndrome. The widely used term now is the Placenta Accreta Spectrum. What is that? It is the range of the pathological adhesion of the placenta. I am not going into other classification, but this is now the standard classification, FIGO 2018 and 19. This is the classification. Grade 1, just Placenta Accreta. Grade 2, the increta. And grade 3, the parcreta. And grade 3A, it is subdivided, limited to the uterine serasa. Grade 3B with urinary bladder. Grade 3 is the invasion of the other pelvic tissue organ. So grade 2 and grade 3 we are varied. Grade 1, you can attempt the placental delivery, placental manual removal. Associated, but sometimes not actually could not be known prior. But it is the ultrasound, and ultrasound has dramatically reliable now, and there is so many improvement of the ultrasound now. So the ultrasonologist is actually our friend, due to the management of the Placenta Accreta syndrome. Associated with significant morbidity and mortality, most concern is the remarkable rising frequency. How frequency you can see. 100 years back, the incidence was 1 in 20,000. And in 1980s, you go through the book and history, 1 in 2,500. And recently in the 2015, in 2015, the 1 in 731, and recently is the 170. How the frequencies, I think all obstetricians, all of you will get the Placenta Accreta Spectrum. And the responsible is that is the previous cesarean section, prior cesarean section, all of you get. But we want to sleep at night. And how to manage, you streamline the manage. That is the today I have. Cesarean hysterectomy is the treatment of choice following cesarean delivery in diagnosed cases of the PAS, all guidelines says. Complication of PAS, before the streamline management, maternal mortality was high, even 7%, massive obstetric hemorrhage, 3 to 5 liters, DIC, AKI, ARDS, cardiac arrest, injury to the bladder, ureter, bowel, and neurovascular structure, need for hysterectomy, ICU admission, electrolyte imbalance, transfusion reaction, infection, thromboembolism, repeat surgery in postoperative period. What was done, my 30 years experience, I say, first of all, we have tried, we can remove the placenta. We can remove the placenta. And when we can read the placenta, then again we are doing the hysterectomy. That is the patient is already disastrous condition, cardiac arrest occur. So you will have to decision at that time whether I will at all touch the placenta or no. And in these few next 5 minutes lecture, I will show what will be the incision, what will be the ideal incision, what will be the alternative I am showing. The etiology, this is actually theoretical part, I am not going into detail. The direct surgical, the postgraduates, but as the questions are there, what are the etiologies of the placenta accreta spectrum, direct surgical scar, not surgical scar also, endometritis, manual renewal, IVF procedure, IUD, Newton anomalies, there may be placenta. I have got the Newton anomaly with the placenta accreta spectrum. This is the etiologies. And other factor is the constitutional endometrial defect. Many patients without cesarean section, there may be the placenta accreta. And partial or total absence of the pseudoplacental is an imperfect development of the fibrinoid or nitabug maternal age, multiparity, placental biomarkers, maternal syrup, alpha-beta and serum beta seizure associated with the increased possibility. But how they are associated, it is not known. It is the ACOG guidelines says. So why so rise? What is the cause? Can you say any from the audience, madam? Why the placenta accreta spectrum is increasing? Rising frequency of the cesarean section and increased risk factors also. Risk factor. The previous like the surgery, dilatation QSL, and forceful pregnancy in the infertility patient, they have some endometrial defect. And is there any effect of the surgical techniques of the CS? That is the very important question. The surgical techniques has been changed last 10 to 12 years, 15 years. Prior cesarean delivery, the risk rises as the number of prior cesarean delivery increases. Placenta previa is associated in 80% cases, placenta previa. And as you know, when the placenta implant, usually the lower part, and gradually it will ascend when the uterus distended. And you will go most commonly is the posterior placenta previa, postgraduates here, and then the anterior placenta previa. And the placenta previa number is less. But if there is any cesarean scar, placenta cannot migrate. Placenta cannot migrate. So implant there. So that is one of the important reason. And the combination of the placenta previa and history of prior cesarean delivery has the highest chance of the placenta accreta. Important issue, I have said, technique of the cesarean section, type of the suture material. The type of the suture materials was changed, technique also changed, that is from the 3 layer, from the 2 layer, and to the 1 layer. These are the technique, and rapidity of the procedure, different procedure. Now, what is the guideline says, you see that. Single observation, the single layer suture and the suture material used in repair of CS unit may be potential concern of the adherent placenta. As per NICE guideline, the effectiveness and safety of the single layer closure of the uterine incision is uncertain. And except within a research context, the uterine incision should be sutured 2 layers. No question of 1 layer now. And more prospective and multi-case studies are required, this the FIGO guideline says, to evaluate the impact of the surgical techniques used during cesarean delivery, and still unsettled about the technique of the cesarean section on the incidence of the placenta accreta spectrum. Now, antenatal diagnosis we will have to do. It is needed for planning of management, history of first and second trimester vaginal bleeding and USG records of scar pregnancy and PAS, presence of the risk factors, presence of the placenta previa diagnosis, prior cesarean delivery and presence of the anterior low-lying placenta. Always think of accreta, always think. And imaging sonography, MRI. And in the first visit you say, if there is a placenta implanted in the scar, that may be scar pregnancy. And always in case of cesarean section, if one patient comes for the MTP in the MTP, always do ultrasound, whether the scar other will be in trap. If there is a scar pregnancy, always and do the ultrasound, particularly transvaginal pregnancy, ask for the MTP in the early pregnancy with early post pregnancy. Now diagnosis is the following vaginal delivery. It done following the failure to remove the retained placenta manually. During cesarean section, typical findings, you can see the findings. You, those who are doing the cesarean section, you would know, if you touch the scalpel, there will be accessibility. So what will you, your pulse rate will be high and adrenaline will be increased. Inability to deliver the placenta during cesarean section due to absence of the plane of cleavage. Rarely interperoneal hemorrhage. I have seen interperoneal hemorrhage in the placenta accreta, 3C, placenta part 6. Now recently the placenta accreta index has been devised, is not recommended by Julie et al. 2020. Has been proposed to diagnose and predict the severity need for hysterectomy or not. And probably that will come very soon. The number of previous cesarean deliveries, location of the placenta, and bridging vessel, lacuna, and shortest myometrial distance. First trimester color mapping to develop quantification algorithm. Ultrasonography is the first line for the diagnosis of the patient. MRI is not mandatory, but if you suspect that it may be lateral incision or posterior placenta previa, maybe accreta, that is the MRI you do. Sonography, I think the important finding, the postgraduate, this is the common question in the exam, what is the sonography finding by the placenta accreta? Multiple placental vascular lacunae, cystic spaces, loss of hypophytic zone between the placenta and myometrium. There is a hypophytic zone that is lost. And decreased myometrial thickness as the placenta invades, decreased myometrial thickness. Placental bulging in a typical term in the placental bulging. Extension of the placenta into the myometrium, serosa or bladder. And in the colored Doppler, the turbulent lacunar blood flow is the most common finding of the placenta accreta spectrum. Now, MRI may be complement to USG. I have said the depth of the invasion, lateral extension, and posterior placenta. If you suspect, you do MRI. Screening of PAS by the USG. That is the important also. The screening. In women with high risk factor during fetal anomaly scan, placenta accreta spectrum is screened. And there is no clear-cut guideline in number and optimal timing of ultrasound to if you have diagnosed the placenta accreta spectrum in the ultrasound, in the anomaly scan. In asymptomatic women, you do, this is the routine practice, 18 to 20, 28 to 30, 30 to 34. There is no guideline, still not guideline available. And the spectrum of the same disorder, cesarean scar pregnancy and placenta accreta spectrum share the same histopathology. The diagnosis of the CSP in the first trimester should be counseled about the high risk of PAS disorder. And for postgraduate, I say, if I even ask about what is the effect of the placenta previous cesarean section in the gynecological disorder. The important gynecological disorder is the abnormal uterine bleeding, and that is due to the isthmocele. The term few years has come, the isthmocele, and there is a depth there, collection of the blood there, and there is the abnormal bleeding. Even the postmenopausal bleeding may occur. Isthmocele, the term, very important topics for the question in the MS examination. Approach in management in the PAS, planned delivery. A tertiary care center will be done. Delivery is best scheduled for peak availability of all experience. Usually it should be done in the tertiary center. This should be done. Best anesthesis is there, good anesthesis is there, and the surgeon is there. If the pelvic surgeon is available, if you can also, the urologist is also available, placenta accreta diagnose, that is, you should diagnose it antenatally. When to deliver? There is some controversy of the SOG guideline and the NICE guideline. Planned delivery according to SOG, 34 weeks to 35 6/7 is 36 weeks of pregnancy. And RCOG says it is up to 37 weeks of pregnancy. But waiting after 37 weeks and need delivery for bleeding in 50% of the cases. So don't wait after 37 weeks, 36 plus 7 days. Earlier delivery, sometimes if the patient has obstetric condition, continuous bleeding, preeclampsia, maternal comorbidity, labor, PROM or fetal compromise, a risk factor for placental preterm delivery, risk factor. And corticosteroid is recommended before 0 by 7 weeks of gestation. It is not the 34 weeks here. You will have to give this is recommendation. You can see the antenatal corticosteroid in the committee opinion. Now, pre-operative consideration. Always you see the maximization of the hemoglobin level, counseling severe hemorrhage and availability. There is a chance of the severe hemorrhage, you always say, and availability of the blood and blood products and risk of the urinary tract injection. This is the time in the antenatal period. We will have to tell the details of the patient and patient party. If you want to preserve the uterus in this condition, the placenta accreta spectrum, the patient may die. The patient will give, you do whatever you like. And consent for the hysterectomy, many prefer uretary catheterization. This is not routine in your place. Interventional radiology, if available, placement of the balloon tipped catheters into the internal arteries for inflation after delivery, for occlusion, and catheter for immobilization. But this is not so always available. Now, what type of surgery you will do? There are surgery mainly, one is the cesarean hysterectomy and other is the conservative or expectant approaches. You will have to select the case. Cesarean hysterectomy without attempt of the placental removal is the treatment of the surgery. At the beginning I have said. And conservative or expectant approaches are done in very special situation in OX selected cases after proper counseling to the patient. FIGO recommendation on the PAS. In the absence of the spontaneous placental separation, the placenta should be left in situ to minimize the blood loss during planned immediate cesarean hysterectomy, and uterotonics should not be used. Recommended in all settings. This is the evidence base. All settings. And evidence based recommendation is the strong. Total hysterectomy with placenta in situ is preferred over subtotal. You do as the placenta previa, placenta low down, so try to do the total hysterectomy. Otherwise, that service will contain some placental tissue at the placenta previa, obstetric hysterectomy. It is the rule. Recommended only in all settings, evidence low, recommendation strong. Deliberate cystostomy. Suppose I will show the picture. Suppose you are saying the bladder is densely adhered with the uterus. You deliberately do the cystostomy, not the accidental. You do the cystostomy. But because the bladder usually repair with 10 days. If you want to 2 layer, you give bladder usually repair. Otherwise, if you accidental damage, and also the ureter will be damaged. The advantage of deliberate cystostomy is that you will locate what the ureter drains, that is the ureter. Cesarean hysterectomy steps. Now, that is the steps I am going to show. The vertical skin incision is the preferred, and it should be given. Inspection of the uterus after opening the abdomen is done to discern the level of the placental invasion where the placenta is, and to mark the upper level of the placental localization, above which uterine incision is given. It is not the classical incision actually, not the exact classical incision. It is given above the level of the placenta. It may be transfundal, even some case of posterior also. Baby is delivered, the uterine wound closed, keeping the placenta left in situ, hysterectomy performed. If you think you will do the hysterectomy, don't touch the placenta. There will be hysterectomy given. And also the teneximic acid you give, and don't give the oxytocin, the active management of the third stage of labor. That will be the uterus contract and the partial separation, and there will be bleeding. Anesthesia is the regional anesthesia can be done, but there is also provision of there should be provision of that is the general anesthesia. At least 2 large IV cannula should be placed before that. Always in the high risk cases to cannula, but when the patient goes into sac, it is very difficult. All the postgraduate residents they were trying because the vessels already collapsed at that time. So give one prophylactically to large bore cannula. The still picture, then I will go to the video. Vertical skin incision is given, best option for better access. Now the prominent vasculature I have already said, the placental invasion, it itself indicates the placental invasion. To mark the upper level of the placental invasion, above which the uterine incision to be given. You can see the pointer here. You can see the pointer. Can you give me one pointer? You can see there the above the level of the placenta. Above the level of the placenta, you mark there what all will give. Then you do the incision above the level of the placenta. The longitudinal incision, you see this is not the classical. Classical means typical upper uterine incision. Classical. Yeah. So you can see there that is the upper level of the placenta, and that is the transfundal longitudinal. There is also some option of the transfundal vertical incision. There are some types of the cesarean section and uterine artery devascularization. There are some method case report also. But what we do, I am showing you. And this is as there is the placenta lower uterine segment, there is the breech presentation. And the head is delivered, being delivered, and there is a cord around the neck. You see, after the delivery of the head, the placenta cord is clamped and reposed it inside, and it is repaired, uterine wound is repaired. And in contrast to the normal BB, usually it doesn't bleed. You will see, it does not bleed, usually doesn't bleed. As the uterus contracts, there is a little bleeding at that time. We have an idea, there may be upper uterine segment bleeding, usually not, isn't it? But don't give the oxytocin, give the tranexamic acid. And searching, we do routine interiliac ligation. Interiliac ligation is not recommended routinely. And particularly American group, I do not know whether they are expert or not, but because they do not recommend. But in our setup, where there is nobody, we do interiliac ligation and bilateral interiliac ligation, and then we go for the hysterectomy. If there is the problem is the bladder with the uterine adhesion, that is the area of the bleeding. And you can see the interiliac ligation. Here I aneurysm needle or the right angle forceps. Aneurysm, that is right angle. If anyone have gone through my operative obstetrics, you see I have written how interiliac, particularly for the beginners, how you can do the interiliac ligation. Interiliac ligation you can, and also my bedside clinic obstetrics, it has been written. Interiliac ligation to make it safer. How? Because you can use the right angle aneurysm needle. Now mostly right angle forceps, and when you do the interiliac, the posteriorly after the incision over the peritoneum, external iliac and internal iliac, you will division. Internal iliac goes behind and medially, and there is a common fossa of the internal iliac artery and internal iliac vein, and that fossa you will have to separate. If you separate the fossa, then you ligate below the 2 centimeter at the bifurcation. What will happen then? You will escape the posterior division. That is the basic 2 lines. But it is not so difficult. Particularly the interiliac ligation, that is interiliac ligation, we have used the aneurysm needle that. And then hysterectomy procedure for upper clamp, lower clamp. That what is the routine? I am going into detail. The most difficult part is the separation of the placenta, separation of the bladder. There is a meticulous, because the bladder may be involved, or I am giving the picture of the specimen, you will see. That is very important. You do the diathermy and very gently do it, very gently do it. And I have already said that bladder may be injured or open, which is repaired in layer, and postmortem bladder is given. But try not to injure the bladder. Hysterectomy completed, and there is the complete hemostasis. You can see complete hemostasis done, and there you see there is no myometrium. This specimen actually, and there is no myometrium. You can see only the serous causal present, but gently done. And another case you see, that was the no serous coat, and in fact there is the injury of the bladder, and the resident called me. Resident, he was expert. Mostly the male resident in Bengali. He was expert and called me, the bladder is injured. So don't be worried, no problem. This is a bladder injured. And from the back of the uterus, specimen is cut. Now you can see from the back of the uterus another specimen, because the myometrium is also involved. This is actually the video. I am showing the video. That operation. Wait for the program. It will be visible.
आपने कॉपी किया हुआ है वीडियोस में?
हैं?
पेन ड्राइव में कॉपी किया हुआ है?
है कॉपी है।
आपको मैं वहाँ
है उधर में है।
वहाँ से चला दूँ? हाँ चल गया।
अच्छा। You see the incision above the attachment of the placenta is given. Attachment of the placenta. It's a very small video. The snap is the beach presentation, and it is repaired. There is a music here, but this is subsided by the other music. And the repair of the uterus in 2 layers usually. 2 layers is sufficient. Or 1 layer you can give. And now the interiliac ligation you can see. Interiliac ligation in the right side with the aneurysm needle. And I have also done the opposite side, not so near. And then hysterectomy proceeded. Hysterectomy is done. Always use the diathermy. It is a clamp of the fallopian tube, mesosalpinx and ovarial ligament clamp. And for the beginner, when you clamp the fallopian tube, mesosalpinx and the ovarial ligament, you always resuture it after the end of the surgery, because there is every chance of possibility of the loosening of that stitches. After the postoperative period, hemorrhage may occur. Now the separation of the bladder. A Mackendorf's ligament. As we have reached the vault of the vagina, and it is cut, the repair of the vault of the vagina. Repair of the vault of the vagina. Here, there may be sometimes bleeding there. Many expert obstetrician is there, so you have to use the mop. You will have to the mop for arrest of the bleeding. The hysterectomy. Vault is cut. The vault is repaired and the specimen. So these are 4 minutes. Oh, sorry. And he helped me. There is some. Next, we will go to the.
Just press the down.
Yeah. Now, additional therapy you will give to control severe hemorrhage, pelvic pressure packing, and aortic compression. There are different types of pelvic packing. And PRBC and FFP is a platelet in 1:1:4 or 1:2:4. Tenexamet is used immediately prior to or during the cesarean delivery. Uterine training is withheld. If you want to remove the placenta, suppose clinically you have diagnosed this is not so much adherent, is the one type. You will have to give the oxytocin, the prophylactic. Now, unexpected and unplanned discovery of the past. This is the guideline of the FIGO. What will you do? The guideline. If it is seen the placenta parkita is present on opening the abdomen and the cesarean section is delayed till expert person and adequate blood products are available. So at night the resident is doing, there is no surgery, wait for the resident. Wait for the resident. And even before the delivery of the baby. Now mostly is giving the regional anesthesia. And these may need closure of the abdomen and urgent transfer. Sometimes it is a guideline also. So many of you will go to the rural area. You have just accidentally opened. I have seen that doctor has come with that patient after closure before delivery of the baby. Before delivery of the baby and come to the hospital and an expected management, leaving the placenta either partially or totally in situ. Regular follow-up. Problem is the regular follow-up, ultrasound examination, and access to emergency care for complications and need for secondary hysterectomy, if you need it. Methotrexate is not recommended because methotrexate does not work in the dead. Rather, it causes the adverse effect. Conservative management, it defines all procedures that aim to avoid peripartum hysterectomy when woman wants to preserve the uterus. The FIGO 2019 has said different conservative management. What are the conservative? If it is absolutely needed, what is the conservative management? Leaving the placenta in situ or the expected management. Expiratory technique, manual removal of the placenta, that are we used to do previously. One-step conservative surgery, removal of the accreta area. I am showing triple P procedure, suturing around the accreta area. Leaving the placenta in situ, by leaving a placenta, accreta in situ, secondary necrosis, placenta should progressively detach. This is the concept. But regular follow-up needs ultrasound examination and access to emergency care for complication and need for secondary hysterectomy is informed. It is not possible for the rural people of the India. And extirpative technique, the forcibly remove the placenta. I have done previously. And placental villi that have inhibited the deep uterine vasculature increases the risk of the massive obstetric hemorrhage and the need for salvation hysterectomy. Uncontrolled bleeding will lead to coagulopathy and will also complicate the surgical procedure and increase the risk of injuries mainly. And you are not able to remove, there is severe hemorrhage, so you are saying I am doing a procedure for the hysterectomy. So patient at this moment the patient is go to the cardiac arrest. This is actually specimen 2014. I have done 2014. Patient ultimately got the life actually, but ultimately, 12 or 13 blood product. One-step conservative surgery. It consists of resecting the invasive accreta area, partial myometrial resection, followed by immediate uterine reconstruction and bladder. Invasive accreta, only the invasive part and then repair. That is the one step. And it is more surgeon skill dependent, recommended only in the high resource settings. This is FIGO. Triple procedure, preoperative ultrasound, pelvic devascularization, and placental non-separation. Pelvic devasculation by placement of the intra-arterial balloon catheters. Intra-arterial balloon catheters are for anterior division of the internal iliac arteries. Placental non-separation with large myometrial excision and reconstruction of the uterine wall. Novel techniques. If you see the book of the FIGO's literature, you will see there are several techniques in difficult cases. Posterior retrograde hysterectomy via pouch of Douglas, modified radical hysterectomy technique, and use of the bipolar cautery, linear cutting staple device for the hysterectomy, use of vessel sealing device for peripartum hysterectomy. These are the novel technique. It is very important for the postgraduates. So conclusion is that dramatic rise of incidence is of great concern and nightmare to obstetrician. The dramatic rise you have seen. Previously how much it was and now it is 20,000 at that time. And antenatal and now is a 1 into 230 like that. Antenatal diagnosis patient by the USG is very important for optimizing management. Planned cesarean hysterectomy without attempt of the removal of the placenta is preferable and now recommended in obvious diagnosed cases. Conservative or expected management is considered only for carefully selected cases with counseling. It is best to save. This is the last paragraph in my book, both operative and bedside clinics. You see, best to save both mother and uterus. This line is actually from all of your heart. Best to save both mother and uterus. Losing a mother in an attempt to save the uterus is the greatest tragedy in obstetrician. Thank you all.
Thank you, sir, for such a well explained lecture with all the latest recommendations.
Question is related to your previous talk on preterm labor. So you had mentioned in the guidelines that fetal fibronectin levels, if a positive fetal fibronectin test is there is no role of adding progesterones.
No,
it was mentioned in the guidelines.
You have probably the later side I am sure. We will give the progesterone, but there is no such recommendation till that date.
Yes, sir.
There is no such recommendation, but there are some areas you can give the progesterone.
That is what I was asking, sir. In your clinical practice, is the addition of fetal fibronectin to transvaginal scanning for cervical length, would it increase our area of screening for the high-risk preterm pregnancies?
Definitely, but in practice actually I have the government hospital, I do practice majority. So they cannot afford the fetal area of discussion and highlight fetal fibronectin. Methodic state. Role of methodic state. There is no role of the methodic state if you retain the placenta inside and deliver the baby. It has been clearly said in the guideline, particularly only on the living cytotrophoblast, not in the dead trophoblast. It is more harm than the good for the patient. Methodic state has no rule. But I have also used a few years back. But it has been clearly guideline, it is said, no rule of methodic state. But as soon as the baby is delivered, placenta is usually death of the placenta. And then necrosis occurs. If you think.
To build up the hemoglobin, we can use methotrexate, and secondary hysterectomy should be done to build up hemoglobin in between the first surgery.
No, you will have to do the basic.
Sometimes emergency cesarean, emergency placenta accreta.
I cannot hear.
Sometimes emergency cesarean placenta previa cases come and the placenta is retained inside the uterus. And if we try to remove that placenta, there is more chances of bleeding. So it is better to leave the placenta inside and close the uterus. And after building up the hemoglobin.
Now that is the best. But methodic state is the present guideline. It is not recommended. Methodic state is not recommended.
Yes.
Not recommended.
Yes.
But she has already questioned if you think there is some living presentation you can give. But after all investigations, the methodic state has some side effect.
Yes, sir. Yes.
And definitely. This is the updated guideline, what I am saying. At least all of you think, I have presenting this and the methodic state about, you will see the literature tomorrow. You will see what is in the literature, latest literature. But now is the evidence-based practice totally. If you do the hysterectomy, and at least you can quote and also the consumers you can say, this is the guideline. It was the guideline. One of my friend, in one case of the severe preeclampsia, not the eclampsia, the patient died. So she didn't give the antihypertensive. That is the point on the board, members of the board, in consumers. No, it's the medical council, our medical council. You have not in hypertension, you have not then hypertension. He came to me. See, he came to me, what could do? At that time, you can remember the ACOG guideline was that the hypertension, level of the hypertension, giving the antihypertension was much higher. Now it has come down. And at that time. So he was saved that original ACOG guideline. Whatever I see, you will have to ready the whole guideline. Because it will change. You will see the change.
Sir, very well described, sir.
Thank you.
Yes, sir.
Remove the accreta part of the myometrium.
And that is the single Single step.
Single step.
Single step.
Sir, what will be the prognosis now after that?
Now, good prognosis. That is, say, reported and studied on that. Recently, I have not said, if you do the FIGO, there is the box 2 FIGO guideline. What say, you please sit it. Or the transverse. You do the transverse. And you do the uterine devasculature. And in the meantime, assistant will press the uterus against the symphysis pubis so that bleeding does not occur. And uterine devasculation and uterine artery, only to both sides uterine artery, then you try to remove the uterus. And they have demanded that 80% bleeding occurs and placenta uterus can be preserved only by the uterine artery. There are so many methods coming out.
So thank you so much, Dr. Majhi. Practical tips to all our audience. Which gestation you want to terminate, 34, 35 or 36? Placenta accreta.
In my personal experience,
yes.
Actually, usually 34-5 weeks. After the,
34,
we give the 35 weeks, give the steroid,
35
and 35, 36, not more than that. Not 30, not after 36 is never. If the elective I plan 36, because the survival rate almost equal. Survival rate of the baby is almost required.
I personally think that even in case of placenta accreta, we should always categorize whether it is only adhesive or invasive. If it is adhesive, it can be done at various places also. But if it is invasive, it is better not to touch unless it is tertiary center and with very good places.
The experienced surgeon can exchange his views. This is a good chance. The juniors can hear. Because
I think
we
2
have
days back only we had a case of percreta in our department. 2 days back only Dr. Ruchika had this percreta, placenta percreta, which was done in our department. And adhesive cases, grade 1 can be done even at nursing homes and every place. But if it is increta or percreta, it is better not.
No, not in. At least you counsel and whether it will. With risk and counseling with the patient. Thank you.
Established preterm labor. Sir, what are the drugs you are giving in nowadays?
That is another topic actually. That is I have not discussed. Established preterm labor, sometimes it is very difficult and that is progressive. At least 4 centimeter dilatation and that is progressive. And uterine contraction is progressive. The 3 criteria actually. What do you use in your practice? What tocolytic drug use? What are the tocolytic use?
Sir, actually, previously we are using this beta-mimosine.
Duodenal has gone. Isoscepin
Ritodrain
is totally, it is nothing by the water. Duodenal. So you will have to select the other.
Calcium channel blockers we are using.
The nifedipine is a good choice. Nifedipine is a good choice. And also the Ritodin you can give. But nifedipine is a good choice. Usually now give with the nifedipine. Well, you will have to do something.
Sir, if we diagnose a placenta percreta so will extending the pregnancy to 34 weeks, will it increase the maternal mortality? Suppose there is a bladder invasion is at 20 weeks.
Her question is very important question. Suppose the placenta accreta, what happen in practice? There may be scaroptemy in early months, and these is the very early. You will have to terminate everything in the large hospital. And the placenta accreta spectrum, after the maturity, madam has said, after the steroid, you terminate 35. But what will be the 20 weeks? You will have to discuss with the patient. And she is asking whether you will terminate the patient. You will terminate the patient at this moment.
Yes, sir.
Actually, now recently the MTB guideline has been changed. MTB guideline. It doesn't mean that is the all cases you will terminate after 20 weeks of pregnancy. There is a special situation. What is the change in the MTB rule? Up to 20 weeks, only one doctor can. Up to 20 to 24 weeks, 2 doctors will advise. No medical board. But there are some 7 special situations you did. and special situation. And after 24 weeks, and only so congenital anomaly. Only in case of congenital. The epicuous trend, there is a maternal lesion. Maternal lesion is a cause of MTP, or you can say the previous there was also there. But there is a problem is also at that time also 20 weeks.
Sir, if we may finally end up in hysterectomy even at 20 weeks.
Yeah.
And sir, if the patient wants to continue the pregnancy, will it increase the maternal mortality? If we are
Definitely. That is what I have said. The screening is done. You do screen at the 20 weeks. You screen at the less than the 24 to 28 weeks another. And another is the 32 to 34 weeks. This is the not guideline, but it is usually done, the screen, what is progressing or not. But it is known, and the counseling, and better to keep the pregnancy, but it depends on the patient. And according to MTP, suppose severe preeclampsia at 23 weeks, what will you do? Severe preeclampsia and also convulsion, what will you do? You terminate. That is not against the MTP rule. Maternal lesion you can cure. Maternal lesion you can do. But fetal lesion is actually, that is the two medical officer, RMP, up to 24 weeks. After 24 weeks, there is a medical board formed by the state. One obstetrician, on that is radio diagnosis, and on pediatric medicine, pediatric surgery, and whatever they may add.
Thank you, sir.